Okay, let's go ahead and continue on with our chapter 44. This is the second part of the slides. Um, right now, we're going to talk more about just ovarian neoplasms and masses, which there's quite a few. So we'll try to go through what you need to know for your test and just in general. So only about 3% of ovarian cysts that are less than 5 centimeters are malignant. So that's the first thing I want you to know is like the smaller the mass, the more likely it's going to be benign. Cysts that are greater than 5 centimeters are recommended for surgical removal. So if you do see a cyst that's greater than 5 centimeters, that's when they like to either aspirate it or remove it, especially in a postmenopausal woman. Then again, the well-defined anechoic lesions are going to be more likely benign. So simple cysts, thin walls that don't look too complex, those are more benign, while lesions with irregular walls, thick irregular septations, mural nodules, and solid echogenic elements favor malignancy. So if you have more of like a simple cyst, you have a great chance of it being benign. When you have more of a complex cystic and solid mass with septations, it is a higher chance definitely for malignancy. Doppler examination shows a low resistive flow, especially in malignant masses because they want all the blood flow. So they don't want any high resistance. So you'll see a lower resistance pattern, which is a higher diastolic flow. The extension beyond the ovary into the omentum, peritoneum, liver metastasis should be evaluated, especially in stage 3, stage 4 cancers. Ovarian cancers, they like to metastasize quite a bit. You might see malignant ascites. And again, thinly septated cysts are more likely to be benign. And multilocular, thickly septated masses and masses with nodules or malignant. So that's what I want you to know is if you had to compare what a benign cyst and a malignant cyst would be, what kind of sonographic findings would you see in both of those? And that might be something that's going to be on your midterm. Again, the other thing is if you have one ovary that, let's say, has a volume of like 9 mLs, which is usually pretty normal standard ovary, like your right ovary has that, but then the left ovary is like 40 mLs. If that's the case, that could be a suspicious thing that something's going on with that ovary, like it could be malignant. This is especially true in a postmenopausal woman. When the ovaries are atrophic and they don't have many follicles. If you see a very plump ovary that's very easy to find in a postmenopausal woman that is measuring quite large, that's a very significant finding and should be written on your report. The only time that this could be a little bit different is if the woman is having hormone replacement therapy. And if you remember, the endometrium will also be thicker when this happens. So that's why you always want to ask in your, before you get started, if you're on any medications, oral contraceptives, hormone replacement therapy, because that will define what you see on your ultrasound. So ovarian carcinoma, I'm sure you guys have heard of ovarian cancer, and it kills more women than cancer of uterine, cervix, and body combined. And it's honestly the 4th leading cause of cancer death, and it's very scary. Approximately 1 in 70 women develop the disease, and 60% of the ovarian malignancies occur between women of 40 and 60. So why is it? Why does it kill more people? They call it the silent killer because it has absence of symptoms early on in the disease. So you don't even know that you have ovarian cancer until it's probably in the pelvis at stage 2 or stage 3. And by that time, it metastasizes so quickly. So stage 3 ovarian cancer does not have a very good prognosis at all. So some patients complain of just bloating, kind of filling off a little bit, bleeding. Those are some of the clinical symptoms that a patient is going to complain about. Some, when they come in for a pelvic exam and the doctor looks at their ovaries or does the exam, sometimes they can't feel anything. It's almost normal to slightly enlarged. In advanced disease, ascites and omental masses might be seen or palpated. You also have the blood chemistry test, CA-125, that is helpful in some patients, but sometimes it's not. The higher the CA-125 level, the more likely that there's some kind of cancer going on. Nope. So ovarian cancer can present as either complex cystic or solid masses. They're more predominantly cystic, and as many as 20% are bilateral. Again, masses that are less than 5 centimeters and longest axis tend to be more benign, and masses greater than 10 centimeters are more likely to be malignant. And the increasing patient age correlates with the increased incidence of malignancy. So the older you get, the higher chance that the mass that you have is malignant. Now, the other unfortunate thing is the incidence of ovarian cancer greatly increased in women who have had breast and colon cancer. And it is related to the BRCA1, BRCA2 genes that a lot of people talk about. They can get tested to see if they have a high chance of breast or ovarian cancer. And if they do have either one of these genetic mutations, a lot of people, well, quite a few people and people I've even known have decided to go ahead and be proactive, taking their ovaries out. So the strongest risk factor is family history of ovarian or breast cancer. And women with carcinoma of breast have an increased risk of developing ovarian cancer, and women with ovarian cancer have a 3 to 4 times more likely to develop breast cancer. Other risk factors for ovarian cancer is increasing age, nulliparity, never been pregnant before, if they've had infertility, uninterrupted ovulation, and late menopause. So uninterrupted ovulation, that means never being pregnant, or breastfeeding where you're not having a period. And the reason is the more times you ovulate, the higher chance that you have of getting ovarian cancer because of the estrogen increases. So if you breastfeed, it actually, you have a longer period of not having menstrual cycles, and you have that decreases your risk of ovarian and breast cancer in the long run. So that's another reason to breastfeed. So here's the clinical symptoms that I want you to know: vague abdominal pain, swelling, indigestion, frequent urination, constipation, and weight changes. And that could be from the ascites. The sad thing, guys, is over 70% of women first seen by doctors are in advanced stages of the disease. And it just about breaks my heart when, I'm scanning a patient and they come in with these symptoms, and you scan and you see these horrible masses, and you're just like, your heart drops. And it never gets easier because that it's a later stage disease without them even knowing that there is something wrong. So these are the stages. Stage 1 is limited to ovary. Stage 2 is limited to the pelvis. Stage 3 is limited to the abdomen, intra-abdominal extension, outside pelvis. And stage 4 is hematogenesis disease, liver parenchyma, spread beyond the abdomen. These are a couple images of bilateral metastasis. this mass, solid mass right there. You can see these little cysts, little thick septations here. This is all probably part of the carcinoma. Here's another large mass. There's a solid component. This is all a cystic, nasty component here with, look at these little papillary nodules within the wall. That's a sign of a malignant disease. The other thing that you would see if you put vascular flow on this, it would light up quite a bit. So epithelial tumors is our first thing we're going to talk about. And I highly suggest when you guys do your presentation on a serous or a mucinous cystadenoma, because they are very interesting. They account for about 65 to 75% of all the ovarian neoplasms, benign, malignant, and 80 to 90% of ovarian malignancies. So there can be a benign type of epithelial tumor, and there can be a malignant type. The most common types are serous or mucinous. The serous tumors are the most common, so I want you to know that. The mucinous tumors account for 20 to 25% of ovarian neoplasms, so quite a few. You don't need to know percentages because it'll overwhelm you, and it's really not necessary to know those, but you do need to know that the serous and mucinous are the most common, especially the serous is just a little bit more common. So the benign or low malignancy potential is termed adenoma, and the malignant form is adenocarcinoma. So if it's mostly cystic, you would put this here first. So you'd put, say, serous cyst adenoma would be the benign form of this. A serous cyst adenocarcinoma would be the malignant form. Mucinous tumors are less frequently bilateral than the serous types, and there is metastatic spread. So these kind of tumors can be metastasized. This is what they look like. They can get very, very large. Look how large this is. It can't even fit in the screen. And these are the ones I've seen. And they tend to be more serous type. So let's talk about the mucinous cystadenoma. And I love this one. I hope someone does it because these can get so big. When benign, they're mucinous cystadenoma. When malignant, they're cystadenocarcinoma. Look how nasty that looks. So the cystadenoma, the benign type, can be found in women between 13 and 45. They can be so large, they can be 30 centimeters in diameter and weigh more than 100 pounds. So if you've heard stories of people that have tumors that come out and they weigh like 80 to 100 pounds, these are the kind of tumors, this mucinous cystadenoma. They're so nasty, they're so big, and I can't imagine having a 100-pound tumor taken on me, how great I'd feel after that is done. But they're very interesting, and they look nasty on ultrasound too. In 75% of the patients with mucinous tumors, ultrasound examination shows simpler septate, thin-walled multilocular cysts. I want you to know that. Sometimes they contain internal echoes. And this is what one of them looks like. Again, there's no way for us to diagnose exactly what these are, but it is nice to know what it could potentially be. So here are the things I want you to know about a mucinous cystadenoma. They're unusually large. 15 to 30 centimeters, can weigh up to 100 pounds. They're the most common cystic tumor, usually unilateral, cyst filled with sticky gelatin-like material. It's probably what makes it weigh so much. Multilocular cystic spaces. Benign type is more common than malignant, and clinical is pressure pain, increased abdominal girth, of course. And the sono findings is a simpler septate than walled multilocular cyst. If you know that information about this, you'll be good to go. So this is the cancerous form of the same thing we just talked about, and it's most frequently occurs in women 40 to 70 years old. So the older you get, the higher chance of this being a malignant tumor. 10% occur in menopausal women, and they also can be very large and are more likely to rupture than the benign type. So if they rupture, then you can get this nasty gelatin-like gross fluid within your abdomen called pseudomyxoma, and it's loculated ascites and it's malignant. Malignant cysts tend to have thick, irregular walls and septations with papillary projections and echogenic material, compared to a thin-walled benign tumor. Generally have sonographic appearance similar to serous cystadenocarcinomas. Again, you guys aren't going to be able to, and it's not your job to say, this looks like a serous or a mucinous cystadenocarcinoma. You would more describe the sonographic features, but it is good for you guys to know what it could potentially be. This is one very large mass. Look how large this one is. So the mucinous cystadenocarcinoma can be bilateral. They may occur in menopausal women, 10%, large, likely to rupture with ascites and pelvic pressure pain. Sono findings, you're gonna have ascites with hypoechoic fluid, that's the pseudomyxoma, and you're gonna have thick, irregular walls and septations. So the second most common benign tumor of the ovary after the dermoid cyst. So the serous cystadenoma is more common than the mucinous by a little bit. The sono findings is it usually is unilocular or more multilocular with thin septations. And it's usually smaller than the mucinous cyst. They don't have, they don't weigh as much either. Looks pretty much like the same thing as a mucinous. When it's a adenoma and it's not benign, it's going to be more of a very large mass. Look, it's 21.27 centimeters long. It's huge, but thin-walled, and the fluid is going to be more anechoic. So the serous cystadenoma is usually unilateral. It's smaller than the mucinous cyst. It can have multilocular cysts with septations, which when I say multilocular cysts, I mean these little cysts. Same clinical signs are pelvic pressure and bloating. And sono findings, multilocular cysts may have a nodule. When it's cancerous, it has a higher chance of having papillary projections into the mass. Another thing that you're going to get is the thick walls. You see ascites, it can metastasize to mentum, lymph nodes, liver, and lungs. And you'll again have the pelvic fullness and bloating. The difference between the cystadenoma and the cystadenocarcinoma is they're going to be thicker septations with papillary projections. Then they have internal and external papillomas, so like solid parts of the mass. See, this is not as pretty as the other one. Not that either one of them are really pretty, but look how nasty that one looks. Okay, so we're done with those. The next ones are germ cell tumors. Again, please, someone please do a dermoid tumor because they, again, are super interesting. So germ cell tumors derive from the primitive germ cells of the embryonic gonad. And they count for about 15 to 20% of the ovarian neoplasms, with 95% being benign cystic teratomas. So the dermoid cyst is actually the most common ovarian neoplasm. And I see dermoid cyst quite a bit, actually, more than anything else. Besides teratoma, germ cell tumors include the dysgerminoma embryonal cell carcinoma, choriocarcinoma, and transdermal sinus tumor. Often occur as a mixed tumor with elements of 2 or 3 varieties of germ cell. They have an association with elevated AFP and HCG levels. The clinical symptoms include pelvic pain, abdominal pain, palpable mass. It's usually unilateral. 40% of tumors will calcify. Some of them are solid, some of them are cystic. It kind of depends. The one I really want you to pay attention to and learn is this dermoid tumor. They can be small to 40 centimeters. They're unilateral, round to oval mass. They contain fatty sebaceous material. They contain hair, cartilage, bone, and teeth. When you cut inside them, they're all nasty and have that kind of stuff. I mean, they're disgusting, but they're so interesting. So someone please do the dermoid tumor. I love seeing pictures of it. And the clinical is asymptomatic to abdominal pain, enlargement, and pelvic pressure, pedunculated and subject to torsion. Honestly, I did a lady last week that had a dermoid tumor, probably about like 12 or 13 centimeters, and she didn't even have pain. She just had a regular menstrual period. It's a little bit of bleeding in between her periods. I'm like, how is this not causing you pain? The sonophytings are kind of difficult sometimes. I really do feel like dermoids are kind of difficult to see because you're dealing with all of this kind of material here that sound can't get through. So they can demonstrate different patterns. It can be completely cystic. It can be a cystic mass with a very echogenic nodule, which I've seen those with the dermoid plug. I want you to know that. There can be a fat fluid level, which is going to be hypoechoic and then cystic. The one that I really see most of the time that is really difficult to see is the high amplitude echoes with shadowing. Like the tip of the iceberg sign is what we call it. And that's just the teeth or bone hanging out in that mass. No big deal. Other than that, it could be a complex mass with internal septations. So here is one of the complex dermoid tumors, and you can see that this part is more echogenic, probably like more fatty material, but it's pretty easy to see the defined borders. The ones that I usually see though are like this. They're large and you can't quite make out the borders because it just is all shadowing. You can see the tip, but then it just shadows down. It almost looks like gas, and so it's very difficult to really evaluate these. Next up is the dysgerminoma, and you can get lost in all of these different masses. So I'm just going to point out what I feel like you need to know. Do you need to know that it's 15% bilateral? No. You don't need to know this really, that it's pretty rare, but what I want you to know is it is one of those masses that can occur in women that are less than 30 years of age. So it's one of those that actually can affect younger women, and it's not one that is a postmenopausal thing. The other thing I want you to know is dysgerminomas and cystadenomas can occur in pregnancy. And that's what one of those yummy things look like. And that's all I want you to know. I just need you to know that's a germ cell tumor, that it can occur in younger women, and that it can occur in pregnancy. Now, the endodermal sinus tumors are rapidly growing tumors called yolk sac tumors, and that's going to be on your test. It always is. And they usually occur also in younger women, less than 20 years of age. You'll have an increased serum of AFP, and then it'll be more of a solid mass. They have a poor prognosis. And they're the second most common malignant ovarian germ cell neoplasm after the dysgerminoma. Okay, so now we're going to move on to stromal tumors. There's multiple kinds of these: thecoma, fibroma, and Sertoli-Leydig cell tumors, androblastomas. They're pretty rare too. The fibroma and the thecoma I always get mixed up, but yet you need to know these because they always tend to be on your registry. Tumors with abundance of thecal cells are called thecomas, and the abundance of fibrous tissue are called fibromas. Thecomas are usually benign and unilateral, and they frequently show signs of estrogen production. So if a postmenopausal lady starts to have fuller breasts, periods again, like signs of estrogen production, there could be, and then you see a mass, there could be a chance that it could be a thecoma. Those are what those look like. A fibroma compromises 4% of ovarian neoplasm, and it's not associated with estrogen production. If large, it's increasing pressure and pain, and ascites has been reported in 50% of patients with fibromas of less than 5 centimeters. So know that fibromas are associated with ascites. They are also associated with ascites along with pleural effusion, and this is referred to as Meigs syndrome. So you need to know that a fibroma and this Meigs syndrome are connected. Meigs syndrome is where there's ascites and pleural effusion at the same time. Found in postmenopausal women. They're usually unilateral. And sometimes if they get too large, they can TORS. That's what one of them looks like. Okay, so granulosa. This is the feminizing neoplasm from the Graafian follicle. Do you remember Graafian follicle from way back? Like after you ovulate or before you ovulate, it's the one that's about to ovulate. It's called the Graafian follicle. So it's made from these cells. So it's most common hormone active estrogenic tumor of ovary. More common in after menopause. So clinical symptoms are going to be of estrogen production, kind of like the thecoma, precocious puberty, vaginal bleeding, or full breasts. They'll have pain, pressure, and fullness, and they could potentially twist on themselves too. So kind of the same thing, they're going to have a variable appearance, similar to endometriomas or cystadenomas. Again, you won't be able to diagnose from sono which one they are. That's what one of them looks like. You can see all the vascular flow within it. Okay, last thing I want to talk to you about is metastatic disease. Ovaries are more involved with metastatic disease than any other pelvic organ. So if a patient has some other kind of form of cancer, it seems like they like to drop some malignancy over in the ovaries. So metastatic cancer can arise from the breast, upper GI tract, pelvic organs through the lymphatic spread. Krukenberg tumors, which you need to know, drop metastasis to ovaries from GI tract, primarily from the stomach, but also from the biliary tract, gallbladder, and pancreas, Krukenberg tumors. These are the Krukenberg tumors in the ovaries. So with metastatic disease, they're going to see a bilateral and often associated with ascites. Metastasis is usually completely solid or solid with a moth-eaten cystic pattern. There's one of them. It is not good. If you see these, really not good. Lymphoma involving ovary usually diffuse and disseminated and also frequently bilateral. So our last thing we're going to talk about is carcinoma of the fallopian tube, which is very, very rare. And actually, that's really what I want you to know, is that fallopian tube cancer is very, very, very rare. If you do have that, it's an adenocarcinoma. It occurs most frequently in postmenopausal Women with pain, vaginal bleeding, and pelvic mass, and usually involves the distal end. So you're going to see a sausage-shaped complex mass with cystic and solid components. And then clinical and sonographic findings are similar to those of ovarian carcinoma. I think that is it, guys. I know it was a lot of information, but I hope I helped you kind of told you what to really focus on. And next week we'll have our test over it and midterm. So have a good night. Bye.